we have time now for discussion. So if there are questions on the floor, please raise your hand and yes, Kyoko.
Thank you very much for your great talk. I'd like to ask Dr. Hare about retinitis pigmentosa. I'd like to ask you if some of your patients developed staphyloma in the follow-up.
In our series, we excluded patients with a long eggshell length, so we did not see anybody develop any staphyloma.
Yeah, actually, I collaborated with other Japanese institutes, and as far as I know, maybe retinitis pigmentosa is the only disease than myopia which secondarily develop posterior staphyloma. And the type of staphyloma is very narrow type, so I was wondering if we could follow up and if we could confirm the process of development of staphyloma, it might be useful. So thank you very much. It's just like comments. Thank you.
We will definitely look into that. Yeah.
Other questions?
I have a question for Dr. Bonet. So in these patients with keratoconus, did you ever try putting a toric contact lens and seeing whether it would affect the quality of the images?
Well, we have a very high quality of the images with and without contact lenses. Obviously, after the contact lenses, the quality was a little bit better, but it didn't change the choroidal thickness measurement. So it doesn't matter if in keratoconus patients or high astigmatism patients with the Triton subsource OCT, you can perform the scan without any problem.
Thank you.
So can I ask you a question to you? So after, did you check the choroidal change, structural change, after the treatment of keratoconus?
No.
No, not yet, just a single
not yet.
point?
Yes,
okay.
It's the next study.
Yeah, because I think it was related to accommodation to the choroidal structural change, so I'm very interested in the effect of treatment.
Yes, it will be a very
Kyoko again.
Yeah, sorry again. I'd like to ask questions to Alain. Your talk was excellent, and you said that choroidal vein patterns affect choroidal thickness. And in addition to choroidal veins, are there any possibilities that choroidal arteries and where they penetrate might affect the local choroidal thickness?
It's a problem. I find it's difficult today to differentiate on en-face images and also on B-scan arteries from veins, and we are seeing mainly veins. But I have this question for Dr. Sonoda. With your software, would it be possible to distinguish arteries from veins easily?
Yeah, we cannot detect because just using an en-face image, so we cannot analyze the blood flow, so we can't. But you know that halo layers mainly consist of vein.
Yes, of course.
So you analyze vein, right?
Yeah.
Yes. I think so.
Wolfgang.
Yeah, I just have a very short comment to Dr. Semenova's talk. It was a very nice talk, and you mentioned that some of your findings were below the resolution. You should differentiate between precision of a thickness measurement and resolution. If you have a layer that's 280 microns thick, you can resolve it.
Yeah,
you can then have a precision that is sub-micron, much better than resolution in terms of the thickness changes. So you can find with 10 micron resolution thickness changes that are sub-micron precision. So one is precision, the other is resolution.
Yeah, you're absolutely right. Yeah,
just
thank you.
Otherwise it was a very nice talk.
Thank you.
But I have also another question for you. How do you think, what are the mechanisms which drive these changes in the daily thickness of the choroid? Is it driven by systemic blood pressure or cortisol level or something?
Well, you mean during daytime?
Yes.
Yeah, well, actually, as in our study, we couldn't find significant variations. Like, I can only guess. Maybe there are some significant changes during nighttime, again, because of the hormonal status or something like that. But, well, I don't know. But by the way, we also checked the choroidal thickness with spectral domain simultaneously. And there was much more variations because it was manually measured, maybe, I don't know.
Okay. Other questions?
Yes, is it right here? Is it possible for the panel to describe the ability of the technology to image the parapapillary choroid and its function with respect to possibly glaucoma pathophysiology or progressive myopia?
How is to answer?
So glaucoma, the lamina cribrosa is fed by choriocapillaris. So choroid plays a key role in glaucoma disease. So is it possible to image those regions with accuracy or with precision?
Well, I can answer.
We can answer.
This. Well, once we tried to, using this normative database, we tried to compare choroidal thickness, first of all, in the macular and around the optic disc for the glaucoma patient. But it was a small group, and we didn't manage to find any significant variation. But, well, using OCT-A, you can find loss of microvessels in the superficial layer of the retina. But nothing special for choroid, as for my impression.
Wolfgang Dassler?
I have another short question to Dr. Bonnet. There's been studies in myopia in chicken when you give some kind of aberrations or defocus that the choroid acts like a zooming so that it moves the retina forward. Do you think that these keratoconus patients, over the time when they have the keratoconus, that the choroid is thicker because of the aberrations introduced by the keratoconus and there's some kind of visual deprivation and then the choroid gets thicker to have a similar zooming effect like they found out in animal models?
Well, I think that more study must be done, but I don't really think so because if it's due to the aberration with the contact lens, we checked with soft contact lens, rigid contact lens, and scleral contact lenses. So all the aberrations were improved with contact lenses, and we didn't find any statistical significant difference.
Thank you.
Yes, Ramin?
A question for all of you, because all of you have looked to the choroid. Have you in your series any case of a patient in which the choroidal thickness increased during the follow-up or during different measurement by 50 microns or very significantly from one point to another for any reason? Because that's one of the questions. There are small changes that's possible, but if there is some people having pachychoroid, does it acquire them? So they should have some thickness at one day and then 1 year later, 50 microns more, 100 microns more. Any of you, have you any data showing at least in a single patient that the choroid could increase very significantly?
Can I answer?
Okay, can you answer?
Well, we are doing right now another study, and we are, if the inflammatory theory it's real, and we are taking, we are doing the follow-up of keratoconus patient to see if during the evolution of the disease, if the keratoconus is worse, the choroidal thickness is worse. And well, we have a very small sample, but right now we have seen that the choroidal thickness is bigger if there is a worse topography.
But bigger, I mean...
Thicker.
Thicker.
Sorry.
How much? 5 microns or 50 microns?
We don't know
don't
it
know
yet.
yet.
Perhaps next year we can present it here.
Yes, Rick?
I'd like to follow up on Dr. Drexler's question. If you take a minus lens and put it in front of a bird, their choroid will become thicker within 24 hours. And that's an effort to move seemingly to move the retina in the right direction to put it at the plane of focus of the lens and cornea and this additional lens in place. So if you have keratoconus, you have kind of an experiment in nature in which the front part of the eye is too refractive, and we put the plane of focus in front of the retina. And if people are something like birds, then the choroid should get thicker and move forward, the retina forward. So I think Dr. Sonoda's question, also very germane to this, If you treat that, does that affect the choroidal thickness? I think you're misinterpreting that we're implying there's some optical effects. We're not. We're trying to imply emmetropization, which is a process that your eye can change its physiology.
Excuse me?
Yes?
Do you have a response to that? That's Dr. Benet's kind of, it's a question at Dr. Benet.
Yoko?
Yeah, I'd like to follow Rick's comments also. Actually, when we make experimental animal model of chick by goggles, they elongate, the eye elongates, but also they develop keratoconus. So it is very interesting, the shape of anterior segment and posterior segment and choroid work all together. And I have second question, and about Dr. Liebman's question, and why I'd like to ask Alan, why choroid is thinnest around the optic nerve? Because the reason of my question is that when myopia axial elongates, usually the foveal optic disc distance increases. It's mainly increase. And then the area between optic disc and macula, choroid becomes absolutely, suddenly becomes thin. So are there any reason why, already in normal eyes, why choroid is thin there?
It's for? Who can answer?
Why is it?
Good questions.
Is it a question for you?
I think there is some existence of muscles. I mean, the component of in the stromal, there is some muscles between the macula and the disc. So I think it was strongly fixed. I mean, so it's opposite to your opinion, but in my opinion, I think it's macular and optic disc is strongly preserved the structure of choroid.
Yeah, thank you very much. I was just wondering the role of Brooks membrane, because choroid sometimes presses between Brooks membrane and sclera, and Brooks membrane doesn't stretch. So maybe I was thinking about its role, but thank you very much for your suggestion.
There is a question here.
I have a question to Professor Harvey, and if of my great interest, because in our countries in Middle East, we have a lot of retinitis pigmentosa due to consanguinity. Starting from the first, I started to use Topcon OCT in 2007. I did and published a series of patients of retinitis pigmentosa and even the morphological changes that we can find with OCT. But it's very nice to get the vascular architecture of the choroid and the retinal correlation into the retinal thickness and to the retinal pigmentary changes at the periphery, and even to correlate it with the ERG, electrophysiological, and even if we can do multifocal for these patients to detect the retinal sensitivity and to correlate with the vasculature. Because I think the main pathology will be on the underlying for retinitis pigmentosa is the ischemia. And some of the patients I was following with OCT angio, and I presented in OCT Rome in 2016. And really, I think the retinal vasculature is very important in these cases. Did you, in your series, have you noticed anything in the choroidal architecture and thickness in the periphery at the site of the pigmentary changes, which before we thought it's perivascular pigmentations due to rod dysfunction? Is it mainly from the choroidal and the vasculature, or as we think, and it's very well known in literature, it's due to rod dysfunction?
I think it's mainly due to photoreceptor loss, but eventually you may see changes in the choroidal vasculature. And I think because of, there's actually a very wide range in choroidal architecture, as you saw also from the previous study. So it's important to continue to try to correlate visual or functional parameters with all of the choroidal measures.
In your series, you haven't you haven't studied the periphery as well as the macular area. You didn't go to the periphery and correlate it with the pigmentary changes.
Yes, we've only started doing
Only the macular area.
Yes.
Oh, thank you very much.
Questions there?
Do you have, Michael, do you have a question?
I'd like to ask Dr. Semenova if among the patients in whom you measured choroidal thickness in relation to the time of day, did you see some patterns? Because when you pool a lot of patients, then you may cancel out individual patterns related to sleep, for instance.
I see.
And so it would be worth going back and checking if you can classify it into different subgroups, and whether maybe by interviewing your patients again, finding out if there's a relation to sleep.
Yeah, that's a good idea. Unfortunately, we had only like 9 patients and 18 eyes, not enough to do this, but that's a good thing. I think we should do that.
And then I'm also fascinated by the auto-focusing mechanism of the choroid in the birds, so much that we have set up a study of 1,500 children who have been examined at the age of 11 and then at 16 again. And at ARVO, we have an oral presentation this year where the results will come out and answer whether choroidal thickness at the age of 11 has any significance for the change in refraction over 5 years.
See. Yeah. There were some questions there.
Yes, please.
Good morning. Very interested in this topic because we diagnosed my son with keratoconus. But keratoconus in the cornea clinic is very much diagnosed between the anterior and posterior float using the pentacam. It's very unsymmetrical. So have you, any of the panel, any comments regarding looking at the pentacam images and relating that to the choroid thickness? Because the progression of the disease is very much diagnosed looking at the cornea.
Sorry, I didn't completely understand the question. Can you do it again?
Yes, certainly. You diagnose keratoconus as very unsymmetrical. You diagnose it usually with a pentacam and looking at the anterior and posterior float. So have any of you looked at the difference between the diagnosis and the choroidal thickness? Because it's very, very different between eyes and as it progresses.
Okay, well, right now I'm doing a fellowship in refractive surgery, and we are studying those patients having frustrated keratoconus. So those patients who had an alteration in the posterior part of the cornea, but not yet in the anterior part. And that's the study that we are carrying out right now. So we'll see.
Thank you so much.
And other question? I have a question for Rick. Have you an idea of why there is so huge variation among individuals in the hallux layer thickness and vascularity of the choroidal veins, although the choriocapillaries remain relatively constant among individuals?
That is, I think, one of the unsolved mysteries. Part of it is that we often look at the fovea, and there's different patterns of how the blood drains from your eye. So in some people, the fovea is the watershed zone, and there's no thick hallux vessels there. And in other patients, the large choroidal blood vessels start, say, superior to the fovea, and by the time you're in the fovea itself, you have lots of big blood vessels underneath the fovea, and it looks thicker. That's why it makes it a little bit hard to understand about the retinitis pigmentosa paper, because you're really looking at the thickness of the choroid in the fovea, say, and the blood that you're looking at in those large choroidal blood vessels is actually being drained from somewhere else. So you wouldn't necessarily expect so much of a correspondence in thickness of the choroid to what's happening in the fovea. It's what's happening all around the eye. And I think that's the heart of at least part of the problem that we had in this, is that we're looking just at the fovea, and the halar blood vessels are draining blood from somewhere else. And we're looking at thickness of the choroid, and we're looking at a lot of different abstract notions in that process. I don't know what you think about that. But.
Okay, good idea. Thank you. I guess that we have no more questions, and then we could move to the next session. which will be chaired by Dr. Catherine Favard.
Thank you.
It's a deep range of imaging of tumors.
Okay. Thank you. Thank you, sir.